Today, we're stepping into the shoes of diagnostic detectives. We're going to investigate a truly fascinating medical mystery, which is the complex and, honestly, often perplexing world of hypercortisolism. It's a condition that leaves clues literally all over the body, but catching the true culprit? Well, that requires a sharp eye, a lot of great graphics, which we've got for you today, and a very systematic approach. So, let's dive right into this.
Here is our roadmap for the investigation. We'll hit 1. Defining the crime. 2. The clinical crime scene. 3. The obvious alibi. 4. Step 1. Proving the crime. 5. Step 2. Catching the culprit. And finally, 6. Case closed. Let's get started.
Starting off with Section 1, Defining the crime. Okay, first things first, we absolutely have to clear up a common mix-up between two terms, Cushing syndrome and Cushing disease. Cushing syndrome is your broad umbrella term. It applies to any cause of hypercortisolism. Basically, anytime there's just way too much cortisol in the body, regardless of where it came from, that's the syndrome. Cushing disease, on the other hand, is highly specific. It refers strictly to secondary hypercortisolism caused by excessive ACTH being produced specifically by a pituitary adenoma. So all Cushing disease is Cushing syndrome, but definitely not all Cushing syndrome is Cushing disease.
Moving right along to Section 2, the clinical crime scene.
Take a look at this graphic. Excess cortisol just takes a massive physical toll on the human body, affecting pretty much every organ system. The clues are everywhere. We see profound changes in fat distribution that lead to central obesity. Notice the wasting and weakness of the proximal thigh muscles too. Patients will literally tell you they can't get out of a chair easily. And you definitely can't forget the hidden signs like secondary hypertension. That actually pops up in roughly 90% of these cases.
Let's zoom in on some classic forensic clues here for some high-resolution evidence. Look at the stria in this image. These aren't your everyday stretch marks. They're classically wide, violaceous, or purple abdominal stria. This happens because the skin gets so incredibly thin and loses its connective tissue support, meaning you're actually seeing the underlying venous blood. You'll also notice skin that bruises super easily with just minor trauma. And of course, look at the face, the classic moon face. The cheeks look plethoric or flushed because of vasodilation, right alongside that increased bilateral fat deposition.
But hey, a good detective always looks beneath the surface. Cortisol leaves a ton of hidden clues. In the musculoskeletal system, it causes profound osteoporosis, which can lead to pathological fractures or even avascular necrosis of the femoral head. Metabolically speaking, excess cortisol induces severe insulin resistance, and that leads to hyperglycemia. But here is my absolute favorite pathophysiological clue: hyperpigmentation. This only happens in secondary hypercortisolism, where ACTH is high. Why? Well, ACTH is cleaved from a larger precursor protein called POMC. When the body ramps up POMC production to make more ACTH, it accidentally creates more melanocyte-stimulating hormone, or MSH2. This MSH darkens the skin, especially in areas not exposed to the sun, like your palm creases and inside the mouth.
All right, we have our clues. Let's hit Section 3, the obvious alibi.
Before we go ordering a million expensive tests, we have to check the most obvious alibi. You see, the most common cause of hypercortisolism isn't a mysterious tumor, it's us, it's medical treatment. Prolonged exogenous glucocorticoid therapy is the #1 cause of Cushing syndrome. Even inhaled or topical steroids can induce this in susceptible folks. When a patient takes exogenous steroids, their pituitary senses all that excess and completely shuts down its natural ACTH production. This lack of ACTH actually leads to bilateral adrenal atrophy over time. So a careful, meticulous drug history is absolutely vital here. You must clear this obvious alibi before you do anything else.
Now, on to Section 4, Step 1, Proving the crime.
I love a good flowchart, and this graphic maps out our initial investigation perfectly. Our goal right now isn't to find the tumor at all. It's simply to answer one question: does the patient actually have Cushing syndrome? We've got 3 main diagnostic pathways to choose from once we've excluded those exogenous steroids.
To nail down a definitive confirmation, clinical guidelines say we need abnormal results from 2 of these 3 main forensic tests. First, we can try to suppress the system using low-dose dexamethasone, either overnight or over 48 hours. In a normal person, giving dexamethasone tricks the pituitary into shutting down ACTH, and cortisol drops. In Cushing's, the body completely ignores this and keeps pumping out cortisol. Why use dexamethasone?
because it's a synthetic steroid that doesn't cross-react in our lab immunoassays. That's a huge deal because it means we can measure the patient's true endogenous cortisol without the drug messing up the results. The second test looks for the loss of the normal circadian rhythm. Cortisol is supposed to be lowest at midnight, so we look for inappropriately elevated late-night salivary or serum cortisol. And third, we can simply measure the total cortisol output with a 24-hour urine-free cortisol test.
Now, listen up, because this clinical pearl is an absolute lifesaver. Actually, scratch that. It's a diagnosis saver. If your patient is on oral estrogens, like birth control pills, you need to stop them for 6 weeks prior to testing. Estrogen ramps up the production of corticosteroid-binding globulin, or CBG, in the liver. Since most of our basic blood assays measure total cortisol, which includes the cortisol bound to that CBG, elevated CBG will make it look like the patient has hypercortisolism when they really don't. It is a classic false positive, so watch out for it.
Next up, Section 5. Step 2. Catching the culprit.
Okay, we've proven the crime. Let's look at our suspect pool in this graphic. We've basically got two rival gangs. 80% of the time, the culprit is ACTH dependent, meaning a tumor is pumping out excess ACTH, which then overstimulates the adrenal glands. The vast majority of these, around 70%, are pituitary adenomas, our classic Cushing's disease. Another 10% are ectopic ACTH tumors, like a rogue small cell lung carcinoma. The remaining 20% are non-ACTH dependent. These are primary culprits operating totally on their own, usually an adrenal adenoma or adrenal carcinoma, just independently churning out cortisol.
To figure out which gang we're dealing with, we turn to our second diagnostic flowchart. The very first move here is to measure plasma ACTH. This splits our investigation right down the middle. If ACTH is suppressed and low, we know the adrenal glands have gone rogue on their own. It's ACTH independent. We head straight to adrenal imaging. But if ACTH is normal or high, we know we're dealing with an ACTH-dependent cause. The adrenals are just following orders from either a pituitary tumor or an ectopic tumor.
So, how do we tell a pituitary tumor apart from an ectopic tumor, say, hiding in the lung? Well, the physiological differences is actually striking. Pituitary tumors, while mutated, still retain some of their original cellular machinery. They have some negative feedback receptors left. Ectopic tumors, no way. They are completely unregulated. So, we hit them with the high-dose dexamethasone suppression test. A massive dose of steroids will actually force that pituitary tumor to surrender a bit and suppress its ACTH production by more than 50%. An ectopic tumor, it doesn't care at all. It'll show zero suppression. Similarly, if we inject corticotropin-releasing hormone, a pituitary tumor responds with a massive spike in ACTH and cortisol. But an ectopic tumor, lacking those receptors, just won't react.
Keep this quick hit in your back pocket. Not every culprit fits the classic visual profile we talked about earlier. Ectopic ACTH production, like from an aggressive lung cancer, can happen so fast that the patient literally doesn't have time to develop the moon face or the central obesity. Instead, they might just show up with rapid onset hypertension and severe hypokalemia. You've always got to keep your detective radar on for atypical presentations.
Finally, Section 6. Case closed.
We've run the labs, we've cornered our suspect. Now we just finalize the case with imaging to visually confirm the tumor's location before surgery. If it's ACTH independent, we grab an adrenal CT. If our dynamic testing points to the pituitary, we order a dedicated skull MRI. And if we suspect an ectopic source, we're scanning the chest and abdomen. And one final, really critical warning here. If a patient's Cushing's is so severe that both adrenal glands have to be surgically removed to save them, you must watch out for Nelson syndrome. Without any cortisol to provide negative feedback, a previously undiscovered microscopic pituitary microadenoma can rapidly expand into a massive tumor, causing severe hyperpigmentation and dangerous neurological deficits.
So, looking at all these complex algorithms, the hidden clues, the overlapping symptoms, are you ready to crack the next endocrine mystery that walks into your clinic? Because armed with this structured approach, you absolutely have the tools to do it.
Thank you so much for learning with us today. If you enjoyed this explainer and loved all the graphics we use to break things down, please hit that subscribe button for the Mid-Medicine channel. We've got a lot more exciting explainers coming your way. Keep learning, and I'll catch you in the next one.